Hello, and welcome to the Pharmacology lecture on Chapter 21 from your text, Antihypertensive Drugs. Just a quick review about hypertension. I'm sure you all are quite aware of what hypertension is and how many of our patients, and probably ourselves, have hypertension. It affects more than 30% of the people in the U.S. above 20 years of age. And it's higher among African Americans, and also the percentage gets higher with age. 50 to 70% of men over 55 have hypertension. There's few symptoms in the earlier stages, so many are not aware that they have this disease process. We know it can lead to cardiovascular complications like stroke and heart failure. Also, it puts stress on the kidneys, so it can create renal disease, blindness, and other complications. Let's talk about the definition of hypertension. Hypertension is defined as a diastolic blood pressure over 80 millimeters of mercury or a systolic blood pressure over 130 millimeters of mercury. And I want you to note that this is a discrepancy with what you're going to read in your textbook. In 2019, the American Heart Association and other health organizations updated the classification of hypertension. They eliminated the pre-hypertensive category that used to be that 120 to 130 millimeters of mercury, and changed the treatment recommendations so that it's recommended that people get treated earlier, sooner with hypertension. Please see the chart on the next slide that updates you on the current levels of hypertension and definitions. Despite whatever the numbers are, the treatment goal is 120 over 80 for blood pressure, basically. It's significant for therapies because drugs for hypertension can affect heart rate and vascular response to exercise. They can impact mobility training. You may have to take them under consideration when you're using physical agents, and you can also have other rehab interventions that can be impacted by hypertension and or hypertension medications. This is that chart of blood pressure guidelines from the American Heart Association, and you'll see now they go hypertension stage 1, 2, and 3. We usually look for our patients to be in that mid-range, stage 2, which is 140 over 90. That's generally considered, if you're going to exercise somebody or be active with somebody, that they are staying below that level. Obviously, more like 120 over 80 is preferable. Let's take a little review of the normal control of blood pressure. The factors that control blood pressure normally are that baroreceptor reflex, which we talked about in Chapter 18. You can review your notes from that. That alters cardiac output and peripheral vascular resistance. The kidneys also help control blood pressure. They're more of a long-term control through fluid and electrolyte balance. And there are also factors in the blood. An example of that is circulating catecholamines or angiotensin II, other factors, and they have varying effects, and they're especially active with sudden decreases in blood pressure. And there are also local chemicals in the vascular system that affect vascular tone and also can affect the leaching of sodium in or out of the vessels. So bottom line, blood pressure is related to cardiac output and total peripheral resistance in the vasculature. So all those things we talked about are going to influence those two systems, cardiac output and total peripheral resistance, or TPR. So changes in these factors are going to maintain or disrupt blood pressure. So the formula that you'll see in your book and other places is BP equals CO, cardiac output, times TPR, or peripheral vascular resistance. We usually talk about two categories of hypertension, and I'm going to give you the second one first, actually, which is secondary hypertension, and that's something that's attributable to a specific abnormality or disease, like a kidney disease or a tumor somewhere in the vascular system or in the kidneys that affects blood pressure. So that's something you can trace to a specific organ or disease. The more common, 90% of cases, is what we call primary or essential hypertension. And that has no one identifiable cause. It's probably a really complex mix of multiple genetic and environmental factors. We know that some risk factors are known, and I'm sure you're familiar with this list. Diet, stress, smoking, alcohol abuse, obesity are all known to be directly related to primary hypertension. The sympathetic nervous system, which we've been talking about a lot, may actually be the final common pathway in mediating and perpetuation of the hypertensive state through excitatory effect on neurons in the heart and peripheral vasculature. So although those other factors may in fact stimulate that sympathetic system and cause initially usually an increase in cardiac output, and then later an increase in peripheral vasculature resistance. Unfortunately, once that hypertensive state starts, it's kind of self-perpetuating. And there's a diagram in your text and also on the next slide here that kind of describes that chain of events. You get decreased baroreceptor sensitivity and changes in renal function, and an association probably with metabolic abnormalities, particularly when somebody has what's called metabolic syndrome. And if you're not familiar with metabolic syndrome, it's dyslipidemia and insulin resistance and usually abdominal obesity. And that kind of group of traits leads to what's called a metabolic syndrome. And then you get the decrease in vessel compliance and a defect in the production of vasoactive substances in the vessel linings. So once it gets started, all those changes kind of make it worse or make it perpetuate. And again, this next slide is just a chart of the possible mechanisms in essential hypertension. Diet, stress, genetic factors all impacting hormonal activity and decreased baroreceptors, increasing central activity at the hypothalamus and the brainstem. You get exaggerated sympathetic outflow, and that changes function at the kidney, where there's failure to adequately adjust fluids and electrolytes, and at the heart, where you have increased cardiac output and or increased vascular resistance. All of those which lead to increased blood pressure, which lead to structural and functional changes in the heart and the vasculature, and you loop right back around to those affecting the central activity. So it's a kind of vicious cycle once it starts. So our goal though for today is to mostly talk about the drug therapies that we're going to use to treat hypertension. And I'm not going to list a lot of drugs. And there are very good tables in your text. So you can start with seeing table 21.2 and table 21.3 that talk about the different types of drugs and give you examples of each type. But we are going to talk about those classes right now. So the first class of drugs used for hypertension is called the diuretics. And you probably have all heard of those, I suspect. Because people complain that they take diuretics and it makes them pee a lot, and that is the exact purpose. It increases the renal excretion of water and sodium. By doing that, it decreases the vascular fluid volume and thereby the blood pressure. So it does increase urination. These have been used for a long time, 50 years and more, and are very often one of the first drugs somebody will be put on if they are diagnosed with high blood pressure. They are inexpensive, easy to come by, again effective in mild to moderate hypertension, and they often can be used in combination with other hypertension meds. And again, because they decrease fluid volume, they're used in congestive heart failure as well. And diuretics are divided into a few different classes. The thiazide diuretics are the most frequently used. So you might hear hydrochlorothiazide. Anything that you hear azide at the end is probably in this class of thiazide diuretics. You may also have heard of loop diuretics, and they're called loop diuretics because they have their primary effect at the loop of Henle. So that's how they affect the fluid volume from the kidney. And there are also potassium sparing diuretics. These are a little newer, and these prevent the secretion of potassium at the distal tubule and change the function of the potassium sodium exchange. The good things about this is that there's less risk of hypokalemia, which is too little sodium, which is a risk factor with the other types of diuretics. So while we're talking about risk factors with diuretics, they're pretty obvious, I think. Electrolyte imbalance, because you get that sodium depletion and or potassium depletion, so you can get hyponatremia, low sodium, or hypokalemia, low potassium. That can produce cardiac and metabolic problems. The other thing we said is you're peeing a lot, you're getting rid of a lot of fluid, so that can cause fluid depletion. And then you can get a reflex increase in cardiac output and peripheral vascular resistance because of activation of those baroreceptors. They go, wait a minute, we don't have enough blood volume or fluid volume, so now we have to increase the output, and that can increase the demand on the myocardium. It could also activate the renin-angiotensin system, which we're going to talk about in a couple of minutes, which will actually further increase the peripheral vascular resistance and make more work for the heart as well. So those would be both of those would be defeating the purpose of taking this to decrease your blood volume and decrease your blood pressure. You can also occasionally get impaired glucose and lipid metabolism, again, especially with somebody who has that metabolic syndrome and already has problems with those things, then this could possibly be an adverse effect. The things that you're going to want to watch for in the clinic that are going to be most obvious then are orthostatic hypotension, again for low fluid volume, GI disturbances, weakness and fatigue, and occasionally even changes in mood and confusion if the electrolyte balance or the fluid depletion get more severe. So those are, on this set of slides, I've put like clinically important things. Not that it's not all important, but the things that I think you should be watching for in the clinic in blue. So we'll start on this slide with things to watch for in the clinic: orthostatic hypotension, GI disturbances, weakness, fatigue, or changes in mood or confusion. The next class of hypertension drugs we're going to talk about are called sympatholytic drugs. And the table 21.4 has examples of this. And they're just what they say. If we remember from last chapter, something that's sympatholytic interrupts sympathetic activity. So the class of sympatholytics, the main one that we already have talked about really is beta blockers. So remember, there's beta 1 and beta 2 blockers, and they tend to have names that end in OLOL, propranolol, OLOL at the end. So those are the names to look for beta blockers. And they decrease heart rate and reduce cardiac output, which we know is what happens when you stimulate beta 1 receptors. They can also produce a general decrease in sympathetic tone, which may affect blood pressure in a number of different ways, through the central nervous system, the kidneys, the baroreceptor sensitivity, etc., a number of secondary ways. These are again often used in combination with other antihypertensives. So you may have a diuretic and a beta blocker, or a beta blocker and an ACE inhibitor, which we're going to talk about in a minute. There are different beta blockers with different specificity, so they can have additional, you're looking for one with desired effects, which may be vasodilation, act as an antioxidant. They may decrease insulin resistance, all by those kind of secondary, more generalized effects that they have. So you want to pair the choice of beta blocker not only with the primary hypertension, but also potentially with this secondary condition that may benefit from that particular drug. We've talked a little bit already about the adverse effects of beta blockers. That possibility of bronchoconstriction, you should remember that from the last chapter. We talked about they can have a bronchoconstriction effect. You might get an excessive decrease in heart rate and cardiac output, which we don't want. And again, the things that you're going to see then are orthostatic hypotension, depression, fatigue, GI disturbances. There can be allergic reactions, usually rash, fever potentially, and a decreased maximal exercise capacity. You also have to watch with beta blockers. Somebody who's on beta blockers is not going to have a normal heart rate response to exercise because we are artificially decreasing their heart rate and cardiac output. So this is somebody for whom heart rate measurement is not going to be a great judge of their effort. You may have to go to something like a perceived exertion scale to find out how much this person really needs is exerting themselves during exercise rather than using heart rate. You also should be monitoring their blood pressure. The other class then of sympatholytics are alpha blockers. We talked about beta blockers. Now we got to talk about those blockers that affect those A1 and A2 receptors. So these cause a decrease in peripheral vascular resistance. They may also help improve lipid profiles, and they may produce some positive effects on glucose metabolism and insulin resistance, and they also can treat benign prostatic hypertrophy, which we talked about a little bit too last chapter. One of the ways we avoid having negative side effects of these, because they can cause a sudden decrease in blood pressure. If you get all of a sudden a large proportion of the vasculature relaxes, you can get a sudden decrease in BP, and we've talked about what can happen then, reflex activities. But we fix that or try to prevent that by using controlled release and slow release versions of these drugs. So there's a drug called doxazosine, and that's linked to what's called the gastrointestinal therapeutic system, or GITS, and that's a way to do a slow release GI admission route for this drug that prevents some of those secondary side effects. Usually alpha blockers are included in treatment with more severe cases of hypertension. And again, just like with the beta blockers, the drugs can be more specific to certain receptors and therefore be chosen for those selective effects. The adverse effects, again, baroreceptor reflex response. You dump the fluid volume, the perceived fluid volume by decreasing the peripheral vascular resistance, and the baroreflector goes, oh my God, I need more blood, I have to do something, and alpha blockers are going to cause reflex tachycardia. Again, to prevent that, you can administer the alpha blocker with a beta blocker that's going to prevent tachycardia, or use that controlled release version. The primary thing you're going to see in the clinic with orthostatic hypotension, it's a pretty significant risk, is again, orthostatic hypotension, dizziness and syncope with activity in particular, or changes in position. There's also a possible increase in risk of heart disease, including congestive heart failure, secondary to that increased workload on the heart, because the heart's compensating for that decreased peripheral vascular resistance. The next type of sympatholytic we're going to talk about are presynaptic adrenergic inhibitors. So these actually decrease norepinephrine. Okay, so if you have less norepinephrine, you're going to get a decrease in sympathetic activity, and you're going to get a decrease in blood pressure. Reserpine is the only drug in this category in the US, and it's always used with other drugs. These have pretty severe secondary effects: decreased heart rate, arrhythmias, drowsiness, depression, GI disturbances, so they're not used very often. Another class are called central acting agents, and these are ones that are kind of target the brainstem parts of the sympathetic system. So you inhibit sympathetic discharge from the brainstem, and that causes decreased sympathetic outflow, which causes a decrease in cardiovascular stimulation and blood pressure. And the effects of these are also dry mouth and sedation, which we talked about with other things that affected that central sympathetic system, and dizziness as well. So those should be kind of familiar to you from our last couple of chapters discussion of the central sympathetic symptoms: dry mouth, dizziness, sedation. The other category of sympatholytics are ganglionic blockers, they're called. And these are nicotinic cholinergic antagonists. Okay, so we've talked about a lot of nicotinic things, but this is nicotinic. And these have a really dramatic effect and are rarely used. Basically, they're used in emergency situations for blood pressure control and for some more extreme mood disorders. All right, the next class of drugs we're going to talk about are vasodilators, and you'll find those on table 21-5 in the text. What these do is they increase the intracellular production of some second messengers like cyclic guanosine monophosphate, and that in turn inhibits the contractile process within the vasculature in the vascular smooth muscle, and that creates vasodilation and decreases blood pressure. So we're actually changing the vascular tone with smooth muscle tone with these. Some examples of these are hydralazine and diazoxide. Another drug that's in this category is nitric oxide, which we talked a little about last chapter 2. That can be inhaled to treat pulmonary hypertension associated with respiratory distress syndrome. These are generally used when other drugs aren't effective or when somebody's in a hypertensive crisis. Adverse effects can be severe, which is why they're only used in crisis situations. Reflex tachycardia, dizziness, orthostatic hypotension, weakness, nausea, fluid retention, headache, and increased body hair, which makes them very unpopular, particularly with women. All right, the next class are renin-angiotensin system inhibitors. And we're going to call that RAS, the renin-angiotensin system, so I don't have to try to say that repeatedly and get all tongue-tied. That's probably something you've heard of. The back of your brain is going, oh yeah, sometime I knew about that in my history, but let's give it a quick review. The reason it's significant is because some patients with hypertension have increased levels of circulating renin. And thus, since renin creates angiotensin II, they have problems with this system in some specific organs or tissues. We'll give a quick review though of what normally happens in the renin-angiotensin system. Your body produces angiotensin, and normally a fall of blood pressure cues your kidneys to secrete some renin. And renin then helps angiotensin be converted to angiotensin I. And then there's an angiotensin converting enzyme, usually in the lungs and some other tissues, that helps angiotensin I be converted to angiotensin II. Angiotensin II then causes vasoconstriction, which increases blood pressure. It causes an increase in aldosterone release, which signals for an increased retention of salt and water. And you get some over time, you can also get vascular remodeling and hypertrophy, which decreases vascular compliance. All of those things together are going to increase blood pressure. So this is normally a system that your body uses to respond to falls in blood pressure or low blood pressure. Okay, so what happens with somebody with problems in this system with hypertension is, again, they have increased circulating levels of renin and consequently of angiotensin II. And so you get extremes of all those third layer effects: vasoconstriction, increased aldosterone release, and vascular remodeling and hypertrophy. The last one is particularly problematic because it can result in thickening and hypertrophy of the vascular wall, which is going to increase peripheral vascular resistance, which is going to keep blood pressure elevated. Can also, whatever this is that this RAS system problem has, can also end up with inflammation of the endothelium, which can get increased lipid accumulation. Again, all of those lead to increased blood pressure and increased number of cardiovascular events. So we have RAS targeted drugs. So there's 3 strategies basically to block undesired RAS effects. One is an angiotensin converting enzyme inhibitor. Remember we said that was the enzyme that converted, once renin converted angiotensin to angiotensin 1, we needed this enzyme to convert angiotensin 1 to angiotensin 2. So if we have something that inhibits that enzyme, will decrease that conversion and production of angiotensin 2. Another strategy is to use drugs that block angiotensin 2 receptors on the various tissues. These are called angiotensin 2 blockers, or ARBs, A-R-B, or angiotensin 2 antagonists. So we have blockers and or antagonists, however you want to phrase it. And those are going to keep that excessive angiotensin 2 from having as much of an effect. And then the third way we can approach this is we can use drugs that inhibit renin production or renin function. And these are called direct renin inhibitors. So now the kidney's not effectively creating renin, or it's creating an ineffective kind of renin, modified version of renin, so angiotensin can't be converted to angiotensin 1, and we kind of slow this whole process. All of these can be used alone or in combination with other blood pressure drugs for long-term control of hypertension. They have some advantages and fewer cardiovascular side effects, and again, that decreased vascular hypertrophy is definitely an advantage. And again, because these deal with the system from the kidneys, they can also be useful in treating congestive heart failure. Some of the adverse effects that are associated with these are allergic reaction, a persistent dry cough, particularly with the ACE inhibitors. There's rare hematological effects and renal problems, mostly in people who are already susceptible with renal disease or renal failure. There's a slight risk of angioedema, which is an emergency situation. If that occurs, obviously we don't want swelling of around the heart. And GI problems are also possible because we're with the direct acting renin inhibitors. All right, next class, take a deep breath. Okay, next class of hypertensive drugs are calcium channel blockers, and that's on table 21.5. So these selectively block calcium entry into the vascular smooth muscle or the myocardial cells. So the smooth muscle cells and or the myocardial cells. And then once they get into there, they're going to inhibit the contractile process, and consequently you're going to get vasodilation and decreased vascular resistance, and or if you hit the myocardial cells, decreased heart rate and decreased cardiac output. These were actually originally developed to treat angina and arrhythmias, but they have gained popularity in treating hypertension with some patients because they can possibly help overcome vascular endothelial effects, which we talk might be problematic with that renal with the RAS system and other aspects of hypertension. And they have a small incidence of metabolic side effects. so they are kind of becoming popular. Sustained release versions, again, decrease those possible negative effects. And drug selection is really made by the side effect profile of each drug, because depending upon, again, if you're targeting the smooth muscle or the myocardium or both, each drug has a slightly different profile, and you're going to try to match that to the particular person's needs. Other adverse effects, general adverse effects, swelling of feet and ankles with that excessive vasodilation, orthostatic hypotension, abnormalities of heart rate. We already talked about heart rate, tachycardia, potentially dizziness, headache, or nausea if they affect the central system. And there's questionable increased risk of MI. Again, if they're used properly and with a slow release, it's not really a problem. And also, there's been some reports of association with cancer, but then secondary, not been able to follow that up or prove it. So that's a real questionable effect. One of the things you have to do with people who are on calcium channel blockers, again, because they can cause pretty rapid vasodilation, is you have to avoid doing any kind of systemic heat with people on these drugs. Let's just talk about then in general. We got all these choices. And how do we make a selection for a patient with hypertension? Again, fortunately, we're not really going to have to do that because this is complicated, but we're going to have to help their physician or their caregiver do that. Basically, for the drugs themselves, there's the consideration of the degree of blood pressure elevation, because we said some have more drastic effects than others, and the patient's other comorbidities and or factors. A main key is that those secondary factors. For quote uncomplicated stage 1, which we've already figured out there's no such thing as uncomplicated hypertension, but for stage 1 hypertension without a lot of other secondary factors, initial meds are often those thiazide diuretics, which we talked about. A calcium channel blocker could be a renin-angiotensin system inhibitor, or a combination of those two of these drugs. Now used to be you had to take one of each or more of the different types of drugs, and now prescribing combinations is so common that there are pre-combined drugs for patients to make it easier for patients to take the proper proportions of combined medications. Additional recommendations for non-pharmacological treatment is very important as well, and can be this is where we can reinforce things as rehab practitioners. Again, these things are in blue on the slide for those of you listening and not being able to see. These are definitely things that are our clinical purview. Dietary modifications, an example of that is the DASH program, which is, I'm not remembering what DASH stands for now, but it's decreasing something hypertension. It's a specific diet geared toward decreasing hypertension. The decreased use of alcohol and tobacco, elimination of those if possible, decrease in body weight, regular exercise. Exercise can have a serious decreasing effect on hypertension, both with and without additional medications. So even if somebody is borderline hypertensive, exercise, and it's amazing, it doesn't have to be super high amounts of exercise. It's like twice a week exercise can have can drop their blood pressure several degrees of millimeter of mercury. So super encouraging for that for patients with hypertension. Behavioral modification, things about stress reduction and relaxation are also things that we can reinforce in the clinic environment, and or we can refer to people who need more advanced treatment. So last slide here. not the least important. Actually, it should probably be the first slide, or it should be the first and the last slide. So screening hypertension for hypertension in the rehab setting. Why should you consistently screen blood pressure in your patients in all rehab settings? All right, here's my list. Because this disease has very few symptoms until late stages, you may be able to identify it in time to maximize effectiveness of the treatment and potentially prolonging a healthy life and averting or postponing a major cardiovascular event. You can do that. It'll be an awesome thing for you to easily do for your patient. Because activities in the rehab setting will have an effect on BP, you should want to know what that is, person's BP is, in order to determine the best possible intervention strategy. Because the patient may not be consistent or reliable to monitor their own BP and report to the prescribing practitioner, you can and should. And that would be super helpful to your patient and to the practitioner, because they'll get consistent and accurate information. You do it to monitor for symptoms of blood pressure change during interventions, especially for evidence of orthostatic hypotension for someone on an antihypertensive med. Also, because you are in a great position to provide education about lifestyle modifications while you're already talking about the movement system with your patient. Get moving, improve your blood pressure. So just do it. Take your patient's blood pressure at least on every time you do an initial exam, and preferably on somebody on medications. You should be taking their blood pressure every time you see them. And for somebody who has a less stable blood pressure, throughout a session that could have a blood pressure impact. So I'll step off my soapbox now, but I'm really encouraging you to increase the frequency with which you monitor blood pressure for your patients. One little other caveat that I'm just going to put out, that it's not on a slide, just if your patients ask, or something you might be interested in researching relative to this unit, is when people should take their blood pressure medications. There's some pretty good evidence coming out that some of these medications are more effective if they're taken later in the day, like before at bedtime. We generally have people take their medications first thing in the morning. For some blood pressure medications, that may not be the maximum effectiveness. So something to just something to keep about and stimulate your curiosity. Hope you enjoyed our little review of hypertension medications.